Hello everyone, I'm Dr. Jiji George, Professor and Head, Department of Oral Pathology, Babu Banarsidass College of Dental Sciences, Lucknow. I'm here today to speak about a few epithelial odontogenic tumors, that is squamous odontogenic tumor, adenomatoid odontogenic tumor, and calcifying epithelial odontogenic tumor. So let's take them up one by one. Now, before going into the details of each of these lesions, I would want you to understand the classification of odontogenic tumors by WHO. Now, WHO's classification was modified several times, and we now consider benign odontogenic epithelial tumors in the category where odontogenic epithelium without odontogenic mesenchyme are involved. So, four lesions come under that category. The first one is ameloblastoma. The second one is squamous odontogenic tumor, calcifying epithelial odontogenic tumor, and adenomatoid odontogenic tumor. Out of which ameloblastoma would be dealt with in a separate lecture. And in this present lecture, we would speak about squamous odontogenic tumor, calcifying epithelial odontogenic tumor, and AOT, that is adenomatoid odontogenic tumor. Now, coming to squamous odontogenic tumor, it is a rare benign epithelial odontogenic tumor. And when we come to talk about the odontogenic tumors, we should first understand about the tooth germs, parts of the tooth germ. Now, the tooth germ has got three parts. That is your odontogenic ectoderm and ectomesenchyme. So, the ectomesenchyme is again divided into two parts, dental papilla and the dental sac. So, the ectodermal origin of the tooth germ is basically the enamel organ, also called as a dental organ. Now, from the enamel organ arises your enamel. So, whatever ectodermal part of the tooth arises from the enamel organ, and in case of tooth, that is enamel. So, ectodermal part of the tooth germ will give rise to odontogenic epithelial tumors. So, all the four tumors which I just discussed some time back in the classification, that those tumors would actually be discussed, actually be originating from the enamel organ. Now, for that, we need to go back to remember the histology of the enamel organ. Now, enamel organ consisted of your inner enamel epithelial cells, which later on developed into ameloblasts. Then you have stellate reticulum, stratum intermedium, outer enamel epithelial cells, etc. So these are the basic four layers of the odontogenic epithelium. So the histogenesis actually means what is the cell of origin exactly. Now, first cell of origin would be rests of molasses. Now, what are rests of molasses? These are the cell rests of the Hertwig's epithelial root sheath. Now, Hertwig's epithelial root sheath is a structure which forms during root formation, and it is formed by the combination of the inner and outer enamel epithelial cells. So, the lesions associated with development of the root process will be seen, uh, you know, along with the uh, rest of molasses. Now, coming on to remnants of the dental lamina. Lesions associated with unerupted teeth are basically originating from the remnants of dental lamina. Now, dental lamina remnants are also called as rests of serrae. Now, the third origin would be from surface epithelium of the or the rest of serrae of extraosseous, which are the lesions which are seen outside the bone. That means you can find SOT or the squamous odontogenic tumor outside the bone as well in extraosseous tissues. So when you see them in extraosseous tissues, it can arise from the surface epithelium or the rest of serrae. So that is about the histogenesis of SOT or the squamous odontogenic tumor. Now, it peaks in the third decade with a slight female predilection, and it's more common in the mandible. And there are also cases where there are multiple familial lesions which are reported. Now, radiographically, obviously, it will show radiolucency because inside the mandible, if a tumor is growing, it will obviously break down the bone. So, triangular or semicircular radiolucency can be seen with the apex towards the alveolar crest. So, there can be a hyperostotic border, and sometimes it can be seen pericoronally, that is around a crown which is unerupted. Now, peripheral lesions, that is your lesions in the soft tissues, can cause saucerization of bone. Now, coming on to histopathology, it is very important. Now, from the picture, you can see that there are many tiny islands of squamous cells which are interspersed in a very fibrous mature stroma. So now there are 2 points one has to understand out here. One, the first part is that the stroma is very fibrous and mature, which clearly means that there is no primitive mesenchyme or primitive ectomesenchyme involved in this particular tumor, which again goes on to say that this tumor is purely epithelial in origin. That means it is a pure odontogenic epithelial tumor. Secondly, we can see numerous small islands of squamous cells uh, interspersed in this stroma. Now, these islands have to be distinguished from the malignant carcinoma islands of squamous cell carcinoma. Now, how will you differentiate? So that I would discuss when it comes to your differential diagnosis. Squamous cell carcinoma is a malignancy of the squamous cells, and it's a non-odontogenic malignancy. But they also have islands with squamous cells. The main difference between a squamous odontogenic tumor and a squamous cell carcinoma would be that an SOT, the present lesion, is a benign tumor, so will not show features of dysplasia. Whereas in squamous cell carcinoma, it's a malignant tumor, so obviously it will show very prominent features of dysplasia with very high cellularity and mitotic figures. So that is the basic difference between those two lesions. So as you can see, you can appreciate the squamous islands in varying shapes and sizes, which are interspersed in a very mature fibrous stroma. So that's why we say that there's little variation. There's no variation in cell size and shape. They're uniform cells, but they're found in islands. Now, intraepithelial calcification sometimes can be seen, and sometimes keratin production can also be seen. Now, this is again a closer look at those islands. You can actually see that the islands are varied in shapes, but there is no dysplasia or atypia whatsoever. You can only find that the squamous cells are there, and this has to be even differentiated from a basal cell carcinoma histologically, because basal cell carcinoma cases in the histopathology would actually show peripheral palisading of the islands. Islands would look something like this, but then you would actually find a peripheral palisading in the basal cell carcinoma, which is not present in this particular tumor. So histologically, you have to actually differentiate it from a squamous cell carcinoma as well as a basal cell carcinoma. Now, you can also see SOT-like proliferations in the dentigerous cyst and the radicular cyst. Now, cystic processes are a little different from the tumor, but there are some tumors which are very aggressive, some cysts which are very aggressive and they resemble to be a tumor. But that's not what we're talking about here. They say that this is a benign tumor. The SOT is a benign tumor, but it can show proliferations in the dentigerous and the radicular cyst. Again, this possibility is there because even the dentigerous cyst and the radicular cyst also arises from the odontogenic apparatus. That is, it's all odontogenic in origin. So obviously you will, even this one, this tumor is the odontogenic in origin. So obviously you can have sometimes you can have these kind of proliferations in their walls. Now, differential diagnosis, I've already discussed the differential diagnosis of a well-differentiated squamous cell carcinoma. But as far as amyloblastoma is concerned, there will be amyloblastic changes in the peripheral cells, whereas it's not present in the SOT. Now, as far as amyloblastoma and SOT are concerned, both of them are benign lesions. But how will you differentiate them? You'll find stellate reticulum-like cells and amyloblast-like cells, which are very well differentiated in case of an amyloblastoma. But then in a squamous cell tumor or squamous odontogenic tumor, you would only find squamous cells without any dysplasia. Whereas in a squamous cell carcinoma, you will find squamous cells with a lot of dysplasia. So that's how you differentially diagnose this tumor. Coming on to the next lesion, that is your calcifying epithelial odontogenic tumor. It's also called as the Pinbock tumor because it was first named and described by Pinbock in 1955. So as I already explained, Pinbock's tumor also arises from the odontogenic epithelium, that is your enamel organ. So there'll be a lot of similarity between the histogenesis of all these tumors. So it was earlier thought to be a type of a mieloblastoma or an odonto. So concepts keep changing as and when, so based on the concept change, there'll be a lot of changes in classification as well. So earlier it was thought to be an ameloblastoma or an odonto, but Pinbock later on suggested that it arises from the stratum intermedium or even from the reduced enamel epithelium. Now, stratum intermedium is the squamous shaped cells which are seen very adjacent to the amyloblastic layer inside the enamel organ. And these stratum intermedium cells are very high and rich in alkaline phosphatase activity. So perhaps that is the reason why the calcifying epithelial odontogenic tumor shows a lot of calcifications. Now, the other suggestion was that it arises from the reduced enamel epithelium. Now, reduced enamel epithelium happens to be uh, the inactive stage of the odontogenic epithelial apparatus. That is, once after the enamel is formed and the function of the enamel organ is over, that is when all the cells of the enamel organ will collapse and form the reduced enamel epithelium. So this tumor can also arise from the reduced enamel epithelium. Thirdly, there is formation of amyloid deposition. So amyloid, they believe that is an immune response to stratum intermedium cells. So that's about the histogenesis. Now coming to clinical features, it is seen more in the mandible than in the maxilla. Like your amyloblastoma is also seen more in the mandible. Even your SOT is seen more in the mandible. But the next lesion we're going to discuss, that is your adenomatoid odontogenic tumor, would be seen more in the maxilla. So otherwise it's asymptomatic and posterior region of the mandible. It's painless, expansile, hard bony swelling. Obviously, because any benign tumor is more or less painless until and unless it's going to impinge on or pressurize on some nerve or something like that, or it has some infection or ulceration secondarily. Otherwise, it is usually painless, expansile, means it just expands the bone, the cortex, or the buccal cortical plate and the lingual cortical plate perhaps, and you have hard and a bony swelling. So there can be an egg shell crackling sound when there is a perforation of the bone. That is, the bone will actually become very hollowed out from the inside, that the bony plates will become very thin and shallow. So they can break with the minor trauma. So the most minor trauma can cause eggshell crackling, and this can also cause perforation when the tumor will actually perforate from inside the mandible into the outer soft tissues. So this can cause tooth tipping, rotation, migration, mobility, and root resorption, but it's not very common. So these are basically features of the benign tumor. Now, it's locally destructive sometimes, and 50% can be seen associated with the unerupted tooth. So you can see that there's a unerupted tooth here and there's a mixed radiolucency out here. So when the biopsy is taken, you can actually see the epithelial cells which are very closely arranged. And this is amyloid-like areas. And this red colored area is basically calcification of the amyloid. I'll come to the calcification part gradually. So coming on to radiographic features, this tumor would actually show a range of radiographical features, starting from being radiolucent to mixed to radiopaque. Now, some tumors are radiolucent. That will be the initial phase of the lesion where there is radiolucency. So 32% of the tumors which we come across will be radiolucent, and most of them will be mixed radiolucency. That is, it will have radiolucency as well as radiopaque appearances. And gradually, and that as this tumor matures, it causes a more focused radio opacity. So radio opaque lesions are only 3% when they are usually seen. So the appearance on the radiograph, that mixed appearance on the radiograph, is basically called as a wind-driven appearance due to these small flecks of calcification along with the radiolucency. So having said that, the radiolucency can be either unilocular or multilocular, and at times associated with an unerupted tooth. So when it is associated with an unerupted tooth, it may resemble to the clinician on the radiograph as a dentigerous cyst, because whenever you find something in relation to the dentigerous, in relation to the crown, that is around the crown, you all on the radiograph, you always think in terms of a dentigerous relationship. So that's how the wind-driven appearance would look like. It's alternatingly radiolucent and radiopaque. And in this picture, in this radiograph, you can see that the buccal and the lingual cortical plates are actually pretty much expansile. And here, this lesion is more or less radiolucent, but yes, few radiopacities are there. But at the same time, this lesion, you can see on the lowermost corner, is showing a lot of radio opacity in the lesion. So you can see COT can be of different varying degrees of radiolucency or radio opacity. Now, histopathology, we've already spoken about the histogenesis of this lesion. I said that it arises from the stratum intermedium, which means that it has the capability of calcification, because stratum intermedium is very rich in alkaline phosphatase. So, in this particular tumor, you would actually find proliferation of well-defined squamous odontogenic epithelium in the form of sheaths, cords, or strands. So there's a typical feature of the epithelium where epithelial cells actually lie close to each other, and they have prominent cell junctions. So cell junctions are very prominently seen in this particular tumor. So well-defined individual cell morphology can be seen. That is, whenever you talk about cell morphology, you talk about the cell size, shape, the nucleus size, the characteristic of the nucleus staining, and the cytoplasm. So let's take it one by one. So the shape of the cell can be polygonal, round, or oval, and or sometimes pleomorphic. That means it can vary in its size and shape. And the cell size will be normal squamous cells similar to the oral mucosa. Sometimes you can find irregularly large cells. The cytoplasm will be richly eosinophilic. Now we know that usually the cytoplasm is pink in color, that is stained by eosin. So sometimes you can see clear cell change. So there is a variant of COT called as a clear cell variant of COT. What it means is you find glycogen accumulating inside the cell. So glycogen does not stain using hematoxylin and eosin. So since HNE is the routine stain that we use, there are chances that this glycogen-rich cell will be clear with the cytoplasm. So that is called as a clear cell change. So the nuclear morphology might be highly variable, where you can find single to multinucleated cells. Now, let's see some pictures. Now, this picture is very clearly showing you that the epithelial cells are very closely arranged to each other. And here you can see, where I'm showing the cursor, you can actually see small, very prominent cell junctions. These are the cell junctions that you can see. And you can see that the nuclei is very hyperchromatic and large. And this is amyloid deposition. So this areas of amyloid deposition are seen in between these epithelial cells, which are thought to be an abnormal keratin production. And this will finally be calcified later on and form Lees-Gang rings. So this is again just to show you all the kind of epithelial cell proliferation which you see in a COT. You can actually see that the cells are polygonal in shape, that is varied shapes and sizes, and they have nucleus which are highly hyperchromatic, though this is a benign tumor. Now in this picture, you can actually see that the epithelial cells are there in clusters, but in between you can see large amounts of amyloid. Now all these areas are areas of amyloid. So amyloid will stain eosinophilic or hyalinized in appearance with HNE and red with Congo red. So and later on this amyloid will undergo calcification. So all these areas would have been amyloid deposited areas, which have now become very deeply purple or blue in color. This is due to these are areas of calcification. So having said that, this picture is basically a peripheral tumor, wherein you can see the epithelium above that and an area of connective tissue which is not involved at all. So you can see that the lesion is in the deeper connective tissue, and it is a peripheral type of a tumor. That's a closer look of the calcifications. Now coming on to more examples of better pictures of calcifications. Here you can see how prominent these cell junctions are. The intercellular junctions are in between. That's what you can see, like a small space between the cells. And this is amyloid production. All these areas are amyloid, and these are the calcifying areas of amyloid. So the calcifications which are seen in the amyloid areas are called as Lees-Gang rings. As you can see here, a closer look, the calcification occurs in a very concentric manner, and any calcification for that matter, when it is dystrophic or metastatic, would be in a concentric manner. So that calcification here also is happening in a concentric manner. So these are called as Lees-Gang rings. So as I said, there is a very rare variant of the COT called as clear cell variant of COT. So this is how you see the clear cell variant of COT. That is, you can see that the large cell is now having a foamy look and only the nucleus is stained and the rest of the cytoplasm is not stained. So out here, it's a normal cell with cytoplasm which is eosinophilic in nature. But whereas in some of these cells, you can't actually see the cytoplasm which is eosinophilic. So that is because the glycogen has filled the internal areas of the cell and it does not anymore stain with HNE. So there are a lot of special stains which can be used for identifying amyloid. As far as amyloid is concerned, it will be seen like a very eosinophilic amorphous area in case of a hematoxylin and eosin section. But if you use something like a Congo red will stain amyloid which in bright orangish red color. And at the same time, if you have some specialized microscopy available, you can even use a polarized light microscopy. So in a polarized light microscope, you can actually see an apple green birefringence. I'll come to some pictures in the next few slides. Then you can also use metachromatic staining. Metachromasia is basically a stain which will show different colors in different substances. So the crystal violet can be used as a metachromatic staining, which will show a purplish color. And thioflavine T can be used in the fluorescent microscopy. It will show a blue fluorescence for amyloid. So there are various ways in which you can actually differentiate the amyloid. This is the apple green birefringence I spoke to you about amyloid in a polarized light. So under polarized light, the amyloid will show apple green birefringence. So this is again Congo red, where you can see the bright red color of the amyloid in the connective tissue. And this is again Congo red in the lungs. You can actually see the apple red, Congo red very brightly showing. Red color in the upper picture, that is Congo red, and the picture below you can see apple green birefringence of the same slide in polarized light microscopy. So after a period of time, all the small areas of these amyloid deposition will now join with each other. Once they join with each other, they form calcified areas. So these calcifications will actually spread from one small area to gradually to the adjacent areas. So this is how you find the calcification. So calcification of the amyloid material can give rise to these structures called as Lees-Gang rings. So that's a concentric layer of the Lees-Gang rings. When I say concentric, I mean to say that it happens in increments. So you can actually see that the calcification here is happening in increments. So these are the Lees-Gang rings, which are quite characteristic of a CEOT. So having said that, we'll go to the next tumor, that is your adenomatoid odontogenic tumor. In short, we can call it as a AOT. Earlier, it was called as an adenoameloblastoma. So the very specific point to note about an adenomatoid odontogenic tumor is that it's mostly seen associated with a unerupted maxillary canine in the anterior maxilla. So which means that the most favorite site of occurrence of an AOT would be anterior maxilla, and that too near a unerupted canine. So it is basically seen in the young people. I'll tell you why. Because as I said, mostly the AOT is seen in the anterior maxilla in areas of unerupted canines. So canines normally erupt somewhere around 14 to 15 years or 13 to 15 years of age. So when the canine does not erupt, there is a delayed eruption of canine. That is when, usually the patient would come to the dentist and ask them, I'm not getting the corner teeth. The canine is not just erupting. So when the dentist would actually suggest an X-ray, that's when you can see that the canine is impacted and there might be a radiolucency around the canine. So mostly the canine takes a longer time for eruption because the path of eruption of a normal canine is actually pretty long. So it starts from the floor of the orbit and it comes down. So there are chances that it can get obstructed anywhere in the path, and as a result of which it can also give rise to, a dentigerous cyst surrounding the crown of the canine. So even a dentigerous cyst around an impacted canine would be seen similar on the radiograph as how you might find a AOT. So that is why the reason why it is seen in younger people is because mostly impacted canines are seen in younger adults. So you can even see peripheral lesions in the gingiva where it is seen more in females. Now, one more important point that you all should understand about AOT is that mostly when the patient comes from the clinic, the clinician is going to initially write a differential diagnosis of a dentigerous cyst because he would obviously find a radiolucency in a dentigerous relationship on the radiograph. But then once it comes to the pathologist and you actually take out the tissue for histopathological examination, that's when you figure out that yes, it is in a dentigerous relationship, but it's not a dentigerous cyst. It is rather an adenomatoid odontogenic tumor. So it's a benign tumor. So since it's benign, it would have a very slow growing bony expansion, but it can cause mobility of teeth sometimes and fracture of the mandible if it occurs in the mandible. If it occurs in the maxilla near the canine region, it can even cause a nasal obstruction because canine develops very close to the nose and it would if it's a tumor, it can grow into the nasal area. So I've already told you about the radiographic appearance. It mostly is seen as a dentigerous relationship, that is a radiolucency surrounding the crowns. Now, this is how you find the radiolucency around the crown. So you can see here, there's a well-defined radiolucency around the crown and the canine is not erupted out. Here you can see the other two teeth which are erupted close by adjacent to it, but the canine has not erupted. So that's a pericoronal type of a radiolucency. Now, histopathologically, when I say the gross appearance, I mean to say how it comes to the lab. Initially, from the surgeon would send the tissue in formalin. When it comes to you, it is a rough spherical mass with a fibrous capsule, and the cut surface will be white to tan and solid to crumbly. It can be the appearance can be, the feel can be anything from solid to crumbly. Sometimes you might find some yellow fluid coming out and calcified appearance might be there. So that's a picture where you can actually see the crown of the erupting tooth being embedded in between this area. So if you look at the picture very clearly, this is a outer capsule, the glistening white capsule that you can see. So, and this is the tumor mass. The tumor mass is very irregular, yellowish tan in color. And you can see the unerupted crown of the tooth in between the tumor. So basically the tumor looks as if it is attached to the neck of the tooth. And if you take a radiograph of this lesion, you would actually see that the tooth is fully formed, but it is not erupted because there's a radiolucency surrounding the crown. So this is called as a dentigerous specimen or a dentigerous relationship inside this tooth. So what we do in these cases generally is that we only cut a part of this soft tissue and send it for histopathological examination to rule out whether it is a cyst or a adenomatoid odontogenic tumor. So coming on to microscopic features, first of all, we have to understand it's an adenomatoid odontogenic tumor. So which means that this is an odontogenic tumor which arises from the odontogenic epithelium, but it goes on to give rise to some duct-like features. So the duct-like structures are basically the adenomatoid that, it looks like ducts. These odontogenic epithelial cells will actually start arranging themselves like a duct. A duct has a lumen. So you would obviously find a lot of these lumen containing structures made up of odontogenic epithelium. So let's go into pictures and it will be more clearer. So these are different types of arrangements of the odontogenic epithelial cells, wherein you can see at least 4 areas where the lumen of the duct is very prominent. 1, 2, 3, 4. So if you look at if you have a closer look at these areas, these duct-like areas, you can see that the odontogenic epithelial cells would actually be arranged surrounding the lumen. And the basement membrane would slightly be thicker and it will look like a very dark pink colored ring. That's called as a hyaline ring. So I'll come to that later. And you will find a lot of these solid islands as well, where there is no luminal formation. So all these islands are very, differently sized. But then there is some kind of a uniformity that you find similar kind of cells, but somewhere it is arranged in the form of ducts and some of them are just cell-rich nodules or solid islands. So this is again another picture of AOT, where you can actually see small eosinophilic droplets or hyaline droplets. Now, why do you find hyaline droplets? That's because uh, this tumor basically originates from the odontogenic epithelium. So the odontogenic epithelium and the odontogenic ectomesenchyme in a normal condition would interact with each other and form a lot of inductive material. So when this induction does not take place in full stream, what happens is that there is a lot of these inductive materials which are seen as hyaline layers or hyaline droplets. That is, it wants to produce dentine. The ectomesenchyme first wants to produce dentine. Only if the dentine is produced, the enamel organ can produce enamel. That is reciprocal induction. So reciprocal induction does not happen here because dentine itself is not formed at the first place. So there's no chance of forming dentine. But having said that, the odontogenic epithelial cells will keep exerting their inductive effect on the adjacent connective tissue, as a result of which there will be eosinophilic material. So you can even find microcysts sometimes in these tumors because of these lumen-like areas, and the nuclei are polarized away from the lumen. That is, these ameloblast-like cells, they'll be arranged like a flower surrounding the lumen, and the nucleus will be away from the lumen. So when the nucleus is away from the lumen and we think that they are ameloblast-like cells, there are more chances that the inductive effect which the cell would give rise to will be towards the other end, not towards the apex of the cell, but towards the basement membrane, that is towards the lumen. Okay, so which is why we see a hyaline ring. So let's see some pictures of the hyaline ring. So this is what I meant. This is the tubular, the duct-like area, and these are the ameloblast-like cells. And you can see that the polarization of the nuclei, that shows that the ameloblast-like cells are very active cells here. Odontogenic epithelial cells are pretty active. And you can see that the nuclei of these cells are basically arranged away from the lumen. So which means that the inductive effect will come somewhere here. So that is an inductive effect in a localized area. And this is throughout the lining the lumen. So this is called as a hyaline ring. This picture is showing a duct-like arrangement along with a reversal of polarity of the nucleus and a hyaline ring along the lumen. So that's again another picture of the hyaline ring, which is more clearer. And you can see that in the center there is a lumen which is empty and ameloblast-like cells surrounding it. So sometimes you can see calcification because these hyaline areas can also show calcification at times, very rarely in a AOT. It is more common in a COT where there is calcification, but here also sometimes the inductive material can give rise to calcified areas. So this is called as the center. It is a rosette formation, that is a rose-like arrangement of the odontogenic epithelial cell. This again is a histopathological feature arrangement of the cells in adenomatoid odontogenic tumor. This arrangement is called as a convoluted pattern, where you can see that there are two rows. This is the outer row of the ameloblast-like cells, and this is the inner row of the ameloblast-like cells. And you can actually see that both of them are back to back, and one is polarized towards this end, and the other one, the nuclei are polarized towards the other end. This typical appearance is called as the convoluted arrangement in a AOT. So coming to tubular arrangement, this is how you find a tubular arrangement. You can see that there are long tubes of these odontogenic epithelial cells. These are more rarer, but then yes, you can also see these kind of appearances. So you can see that there's the eosinophilic material which is there near the basement membrane. This actually shows the inductive capacity of these ameloblast-like cells. Had there been presence of ectomesenchyme in this area, it would have formed dentine first. So since dentine is not formed, but some inductive material is definitely formed in these lesions. So you can find internodular epithelial cells. That is, in between these epithelial nodules, you will find more collection of epithelial cells. So this is again another picture of AOT, where you find this is a nodule and you find internodular. These are the internodular epithelial cells. So sometimes you find that these eosinophilic areas will show calcification, because whatever is not actually normal can get calcified. That's a typical tendency of the human body. So here you can see the calcified areas. This would have been inductive areas of induction, and because you cannot have dentine forming in here, there is some kind of calcification taking place. So there's also presence of basaloid epithelial cells. When I say basaloid, it means that it resembles a basal cell. So this is the example of a cystic AOT. That is, like I said, you can have a dentigerous appearance on the radiograph, and sometimes when you take the biopsy, take the tissue out for histopathological examination, you might find a cystic lumen, and a cystic lumen lined by epithelium. But the epithelium does not resemble a reduced enamel epithelium, so we can make out that it is not a dentigerous cyst. But then the epithelium would resemble an AOT. That is, these proliferation of these cells look like a solid proliferation of an AOT, and these cell nests of AOT are found as a part of the epithelial lumen, epithelial lining. So that is when you call it as a cystic AOT. So sometimes you can see AOT associated with other odontogenic tumors. Now that's very important, a point you have to understand about odontogenic tumors. You can find these odontogenic tumors along with other odontogenic tumors, or you can find them along with other odontogenic cysts. So the AOT can be seen along with a dentigerous cyst, or a COT, or an odontoma, or an ameloblastoma, or a COC, because ultimately they all arise from the tooth germ. So because which is the reason why you can see all of them together. Sometimes when they seen along with another type of a tumor, we call it as a hybrid tumor or a collision tumor. So that's about it for today's lecture about AOT, COT, and squamous odontogenic tumor. All the three arising from odontogenic epithelium. Thank you so much for the patient listening.